co-host as well. Welcome, everyone. Thanks for joining us today. We're going to take probably 1 or 2 more minutes to give people an opportunity to jump from one other meeting to our meeting. Happy to have you. I was saying earlier, it's good to see so many familiar names in the room. And then we also have a bunch of new folks joining us. So welcome to folks who are maybe new to the council, new to NIMARC, or new to Kaiser Permanente. Happy you're here. We'll get started probably in 1 or 2 minutes. All right, Vanessa, you should be good with your video now if you'd like. Perfect. Okay, welcome everyone. We'll go ahead and get started. We really appreciate you taking the time to hang out with us this afternoon. My name is Julia Dobbins. I'm the Director of Medical Respite at the National Healthcare for the Homeless Council. And in the summer of 2020, we launched the National Institute for Medical Respite Care, or NIMARC, and we've been doing a lot of work over the last 3 years, trying to create resources around building partnerships, specifically sustainable funding partnerships between medical respite programs, hospitals, and managed care plans. And that's what we're here to talk about today, is a new resource that we've created. Next slide, please. So like I said, my name is Julia Dobbins. I'm the Director of Medical Respite. I've been with the council for 11 years now. I'm based in Nashville, Tennessee, and I use she, her pronouns, and I will pass it to my colleague, Krista, to introduce herself.
Hey everyone, my name is Krista Signor, she, her pronouns as well. I am a program manager with Medical Respite team and excited to be here with you all, located in Tulsa, Oklahoma. Yeah. Pass it back to you, Julia.
Thanks, Krista. So I want to share our agenda for our conversation today. I think that's our next slide. Oh, nope, land and labor acknowledgement. So at the council, we've been really prioritizing our justice, equity, diversity, and inclusion work. And as part of that, we're trying to be more intentional in our training spaces around acknowledging the land and labor, or doing land and labor acknowledgements. And this is a national webinar, but I am based in Nashville, Tennessee. The council was founded in Nashville, Tennessee. So I want to just take a minute to recognize the land where my home is, where my community is, that allows me to do the work that I do. So the Nashville metro area rests on traditional sites of the Eastern Band of Cherokee Indians, Yuchi, and Shawnee tribes. We stand on these unceded ancestral lands of people past and present and honor with gratitude our ability to congregate for this convening today, the land itself and its people. We recognize the immigrant and American-born workers of African, Asian, and Central and South American descent, whose labor remains hidden in the shadows, but still contributes to the well-being of our collective community. If you're interested in learning a little bit more about the land where you live, I highly encourage you to check out Native Land. The website is native-land.ca. It's just a really awesome resource. Next slide, please. So now I'm going to talk about the agenda for our conversation today. So we did a quick welcome and want to do some housekeeping real quick before we dive into the content. Also, what we're focusing on today is a new resource that we've developed around building partnerships between medical respite recuperative care programs and managed care plans. And the work that we've done on this resource was done in partnership with our friends at Kaiser Permanente. Actually, the idea for this resource came from conversations with Kaiser Permanente. So I'm excited they're here with us today. They're going to talk a little bit about their work in medical respite care. And then I'm going to do just a brief foundational piece around medical respite. And then Krista's going to dive into this resource and really share some of the highlights of what this resource looks like and how we hope that you use it. And then we're moving into a conversation with Pam Mokler, who's joining us, and Julia Gaines, who are representing the managed care plan perspective and the recuperative care plan perspective, to have a conversation about what these partnerships really look like in practice. And then hopefully we'll have time at the end for some questions and discussion. Next slide, please. So, like I said earlier, this resource was developed in partnership with our friends at Kaiser, and we have a couple of folks from Kaiser joining us today, and I'd love for them to introduce themselves and share a little bit about their work in medical respite. Vanessa, I'll pass it to you first.
Thank you, Julia. Thank you, Krista. So happy to be here with you all. For Kaiser Permanente, housing is health, and we understand that without a safe place to call home, it's nearly impossible to focus on basic health and medical needs. So my name is Vanessa Davis. I serve as our national program lead for Kaiser Permanente's Housing for Health portfolio. And for several years, Kaiser Permanente has led efforts to end homelessness and preserve affordable housing by making impact investments in affordable housing, helping to shape policy, and really catalyzing innovations through partnerships like the one with NYMARC, which brings us here together today. We know that we cannot solve the affordable housing and homelessness crisis alone, and it's really only through some of these innovative partnerships and strategic investments that we can take steps forward. It truly will take a multi-sector effort to end the epidemic of homelessness. And this is really why Kaiser Permanente has been partnering with the National Institute for Medical Respite Care, as Julia mentioned, for several years to expand the capacity and state of the field knowledge for recuperative care programs really across the country. We have seen for years the critical role medical respite plays really in the ecosystem of health and housing. And in this moment, we're truly seeing a sea change with regards to how health systems, and in particular payers, partner with and engage with medical respite providers as states increasingly seek to address health-related social needs, or SDOH, through their Medicaid programs. So the need for more resources, tools, and best practices to support these connections is more pressing and more evident than ever. So that is why we're so excited to have had the opportunity to work alongside NYMARC to support the development and now the launch of the Medical Respite Playbook to support these critical connections and best practices. So before I turn it over to Tiffany to introduce herself, Tiffany Huang, I wanted to just take a moment to acknowledge and appreciate Julia and Krista and the whole NYMARC team, my KP colleagues on this call, and of course, all of the medical respite providers, health system partners, and payers who really contributed to the development of this playbook. Tiffany?
Thanks, Vanessa, and hi, everyone. It's so great to be here with you today. I'm Tiffany Huang. I work with Vanessa on our Housing for Health portfolio within Kaiser Permanente's Office of Community Health, and I have the privilege of partnering with our NYMARC team. I'm going to spend a couple minutes just talking about our medical respite initiative specifically. As Vanessa mentioned, we recognize the changing landscape and emerging opportunities with the launch of CalAIM and Medicaid waivers in other states. And it really became clear that medical respite was a natural place for us to invest our time and resources to help move the needle, especially as medical respite care, recuperative care, sits at the intersection of health and homelessness. In 2022, we launched our Medical Respite Initiative with the aim of strengthening the ecosystem of medical respite providers and advancing the field of medical respite through a nationally scaled partnership with NYMARC. The initiative is intended to build the capacity of medical respite providers through a three-pronged approach. So the first is through project funding. We also have targeted technical assistance and training, and then lastly, a peer learning network. And to date, we have supported a first cohort of 21 medical respite providers across our footprint. And funding is helping enable programs to increase adherence to national standards of care, improve clinical and operational quality and performance, And lastly, respond to local community needs. As part of our core partnership with NIMARC, we're also deepening the Medicaid efforts through the development of resources and trainings like the playbook to facilitate partnerships and contracting. So we're so excited to sponsor the development of the Medical Respite Playbook and hope that this will be a useful resource to advance the field of practice, as well as build partnerships between medical respite providers and managed care plans. So with that, I'm going to hand it back to Julia to talk more about the playbook. Thank you.
Thank you, Tiffany, and thank you both, Tiffany and Vanessa, for joining us today and for your great partnership over the last few years. And moving forward, we have some really exciting projects in partnership with KP over the next year and a half, which you'll be seeing a lot of in the coming months. So like I said earlier, I'm going to do just a quick overview of some foundational medical respite information. I'm not going to spend too much time on this because I think everybody on this call is familiar with medical respite care, but I just want to make sure that we're all on the same page. Next slide, please, Krista. So how we define medical respite care, it's short-term care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the street or in shelter, but who don't require hospital level care. So it's short-term residential care that allows people the opportunity to rest, to recover, and to heal in a safe environment while also accessing wraparound services and having some clinical oversight. Next slide, please. So every time we talk about medical respite care, we talk about how diverse it is, how unique every program is, there is no one size fits all. There's no template that you can just copy and paste for medical respite. But what we have learned over the last several years is that most medical respite programs generally fall into these 4 models of care. So we have this new models of care resource that we highly recommend you take a look at. For programs on the call, I think this resource is really useful in how you describe to your partners what you are providing in your program. Because there's so much diversity in medical respite care, sometimes people see a medical respite program and then they think that's how all medical respite programs operate. So then when they see your program and they're like, why aren't you exactly the same? This is a great resource for explaining the differences between medical respite programs. And really the models of care are separated by the level of acuity you're able to address safely in your program. So in the coordinated care model, this really is focused on care coordination more than anything else. There are no clinical services on site, but this is a safe place for somebody to recover and heal and complete their medications. For the coordinated clinical care model, you might have a nurse on site a couple of days a week who is providing some medication support or medication management. For the integrated clinical care model, you might have a partnership with a federally qualified health center or FQHC, and maybe you are able to do more comprehensive behavioral health services on site or provide substance use services on site. And then the comprehensive clinical care model really is for medical respite programs that are able to address higher acuity issues. So complex wound care, IV medication, those are the types of programs that fall into the comprehensive level. Next slide, please. So regardless of your model of medical respite care, regardless of where you're located, regardless of what type of facility you have, who your partners are, what your budget is, we really believe that these 4 guiding principles are like the pillars of practice for all medical respite programs. So it doesn't matter if you've been around for 30 years or 3 weeks, these 4 principles should be a part of every medical respite program. And those principles are trauma-informed care, client-centered practice, collaborative care, and disrupting the cycle of homelessness. And I want to spend just a minute talking about the disrupting the cycle of homelessness piece. No medical respite program, and I feel like I can say this confidently, no program wants to discharge their clients back to homelessness, into shelter, or to the street. That's not the goal of medical respite care. Medical respite programs and medical respite staff want to move people into stable housing. And that is just not always the reality of what's an option for medical respite care. Medical respite is short-term in nature, and we all know there's a housing crisis in every community in this country. And so stable housing is not always an option when people are leaving medical respite care. That doesn't mean that while somebody is in medical respite that we can't move them towards housing or disrupt this cycle of homelessness. And that can look a lot of different ways. So that could be getting somebody's housing application completed, maybe getting their ID that they've lost. Maybe this is an opportunity for them to practice using the new medical device that they got after their acute stay, or maybe it's a good opportunity for them to complete their round of IV meds and then start practicing independently taking the medication that might be new for them. So these are all opportunities for education, learning, and support that are going to help people once they move out of medical respite and support them in their housing journey. So the other thing I wanted to highlight is the standards for medical respite care, just because it wouldn't be a council or NIMARC conversation about medical respite if we didn't talk about the standards. They're the backbone of the work that we do. I highly recommend you take a look at the standards if you haven't had the opportunity to. These are 8 standards of practice for medical respite care, and they're intended to really be a tool for quality improvement for your program. One thing that I also want to highlight is that we are currently in the process of doing a field test for a certification process for medical respite care, which is moving into a pilot process in partnership with KP next year. And certification is going to be the standards are going to be a significant part of the certification process for medical respite programs. So if you take the time to really go through the standards and learn about the standards, you'll have a leg up once that certification goes live in about a year or so. The other thing that I want to highlight quickly that we'll put in a follow-up email along with the recording of this webinar is a new resource we have on the NIMARC website. It is the Standards Companion. And basically for each standard, it has a list of resources, tools, templates, examples, job descriptions that you can use that will help you demonstrate you meet that specific criteria for each standard. It's an incredible resource. I highly recommend you take a look at it. Okay, I'm going to wrap up and pass it over to Krista, who's going to spend some time talking about the new Medical Respite Playbook. Krista.
Thanks, Julia. Yeah, let's dive into the playbook. Okay. So the goal of this playbook is to provide managed care organizations with information about the philosophy and practice of medical respite care and offer suggestions on how MCOs can most effectively partner with medical respite programs. Over the last 9 months, the process of creating this playbook has consisted of hundreds of hours of planning and discussion with our partners, listening sessions with providers and plans, research and resource gathering, and of course, writing. The draft of the playbook was presented to 2 external stakeholder groups and modified to include their critical feedback. Okay. The Medical Respite Playbook, or the playbook, is made of 5 core sections. Those 5 sections are Medical Respite 101, Program Design, Medical Respite Care and Managed Care Organization Partnerships, Case Study, the State of California, and local level action steps to improve partnerships. The intent of the playbook is really to be a one-stop shop NIMARC resource for managed care plans, and we're really excited about all that includes. So let's go ahead and dive in. Okay. Within the Medical Respite Care 101 and Program Design sections, you'll find information about scope of care, range of services provided, the standards for medical respite, models of medical respite care, and facility types. One of the things I really appreciate about the playbook, though there are many things that I appreciate about the playbook, is that it effectively and efficiently crosswalks between macro, higher level information and micro detailed information. For example, on this slide, you can see the 6 key range of services provided in medical respite care in the top center visual. Then below and beside that visual, you can see examples of more detailed information diving into clinical services, nurse enabling services, as well as the benefits and drawbacks or considerations of each facility type. So it's just an example. Another exciting highlight within the playbook is the housing and the discharge planning process. Julia spoke to this a little bit earlier. This section was included as we are often asked the question, how does medical respite care support ending or disrupting homelessness in our communities? Although rest and recuperation, as well as connection to healthcare, are central components to medical respite care, connection to housing is also a central component. In this section, we take a look at how programs work to connect community members to the homelessness response system, make progress towards their housing goals, and discharge to housing when possible. It is important to note, like Julia said, it's not the sole responsibility of the medical respite care program to end homelessness in their community. However, it is the medical respite care program's role and responsibility to support clients in making meaningful progress towards their housing goals and resolving homelessness with clients when possible. While medical respite care programs may not have control over housing availability, they are uniquely positioned to advocate for housing justice in their community. On this slide, you can see some of the examples that are in this section. In the top right visual, that visual depicts what communities look like with or without medical respite. And below that, you're able to see some of the questions medical respite programs navigate and include in their discharge planning process. For example, have you attempted diversion or prevention with that client? Is the client on all eligible community and public housing wait lists? Has the client been connected to the homelessness response system, received a coordinated assessment? And many more questions are included in the discharge planning process. Finally, I'd like to highlight our examples in practice and our local action steps within this resource. One of our examples in practice, shown in the center of the slide, is a highlight of COTS recuperative care in Petaluma, California. This example in practice provides a medical respite care program overview that currently partners with managed care plans. We are joined today by Julia Gaines from COTS, who will be answering questions on our panel in a moment. In addition, on the right side of the screen, we have an excerpt of our local level action steps to improve partnerships, where we look at issues to address as well as provide action steps for managed care plans. So next steps. As you know, the Medical Respite Playbook has officially been launched and is on the NIMARC website within our toolkit. This is where we need the balloons, Julia. The plan moving forward in 2024 is to create a companion online course with our NIMARC learning within our NIMARC Learning Portal or LMS. This will be a free interactive online course open to everyone. On the NIMARC LMS, we currently have 9 courses, with 3 more coming online in 2024, including this one. So if you've not had the opportunity to check out our NIMARC LMS, we highly encourage you to venture over to NIMARC.org and click on the Learning Portal tab. All right, with that, I'll turn it back over to you, Julie Dobbins. I feel like I'm doing the weather.
Thank you, Krista.
Yeah.
So that's a quick overview of the playbook. You should have received it in an email from Krista last week. If you registered before last week, if not, it's available on our website and we'd love for you to take a look at it. We're going to move now into a conversation with 2 of our panelists here who have joined us. I have a list of questions for them, but if you have questions, please put them in the Q&A and I'll try and get to them. But first, I'd like to start by having them introduce themselves. Pam, would you introduce yourself, please?
Yes. Hi, everybody. I am a gerontologist, and I've worked on many sides of this. I formerly served as the VP of LTSS and long-term care for Care First in California, and then Blue Shield bought us. So I continued with Blue Shield until being asked by National Health Foundation, which is a recuperative care provider in California, to help them get contracts with health plans in 2018. From that, the idea when you're going to hear about California launching CalAIM, which is a major Medicaid transformation program that includes recuperative care as a community support and allows the health plans, the Medi-Cal managed care plans. Medi-Cal is California's Medicaid. It allows them to contract with recuperative care providers and include the cost of that in their medical loss ratio. And so I have been the lead facilitator of a learning network, the Los Angeles Recuperative Care Learning Network, for almost 2 years. Prior to that, we conducted interviews and focus groups with hospitals, with health plans, with recuperative care providers, with foundations, with the county health department, and who expressed an interest in a learning network. So we have been in the trenches, and NIMARC has been our main partner in working through these issues, as has Kaiser. So big shout out to Kaiser, since they are a funder of what we're the whole playbook. We have worked through many issues that you're going to hear about, and I also am a consultant with NIMARC, working with Julia on several other projects, some of them funded by Kaiser as well. So I'm just thrilled to be in this space, and I bring the managed care perspective to the table in where their pain points are, how to best negotiate contracts with them. And it just seems like we get one issue resolved and we have another to take on. So we are all pioneering in this space, and grateful to NIMARC and Kaiser for your leadership in this space.
Perfect. Thank you, Pam. Julia, would you please introduce yourself?
Yes, I just want to first say congratulations to Kaiser and NIMARC and the Medical Respite team on creating an excellent resource. This playbook, it just has so much valuable information, and it's just another one of your, NIMARC's amazing resources to add to the library. So again, my name is Julia Gaines, and I am new to the NIMARC team as the Senior Medical Respite Manager, specifically for California, because as you may have heard, CalAIM is just blowing up in California, and it's really changing the landscape for recuperative care in the state. But my role here is kind of, dual. I'm also been working at COTS Recuperative Care, as mentioned a few slides ago, for about 4 years. We were at Mary Isaac Center, which is in Petaluma, California, and they opened recuperative care in January of 2020, and I was the person that walked into, as I said, an empty room, with 6 beds. And from there, we've just built this amazing program that provides just such, necessary post-acute services for folks that are experiencing homelessness. We currently operate at a coordinated clinical care model. So while we don't have on-staff clinical folks, we do offer, we have our local health center that does come a few days a week to offer clinical services on site. So that's the coordinated clinical care model. We follow the NIMARC standards of care. We have since day one, and it's really helped build our program. And as of 2022, we are now a CalAIM provider in the way that we offer enhanced care management services, ECM, as well as community support. The community supports, in addition to recuperative care, we also offer housing transition and navigation services, housing deposits, and then housing tenancy sustaining services, because we all recognize that the issues don't clear up just because the person has home. Like they need to be continued to have continued support. So I'm just so thrilled to be here today and to have this conversation with you about CalAIM. And thank you so much.
Yeah, thank you for joining us, Julia. So the other thing that's exciting about COTS Recuperative Care is that they're in the process of expanding their beds as well, which is a big deal. And we are really excited to have Julia as part of our team. Yes, now we have 2 Julias on one medical respite team. I don't know, so many powers combined with 2 Julias on one team. But Julia is representing the recuperative care voice, medical respite voice today, and Pam's representing the managed care plan voice today. And we know that these 2 styles of operation, I will say, can be very different. And as Vanessa was saying at the beginning of the webinar, what we're seeing across the country really as medical respite care is becoming more a part of the conversation and is not quite as niche as it used to be, is we are seeing more and more states starting to look at Medicaid reimbursement for medical respite services. California was the first state to take this big step a couple of years ago. Washington now has taken that step. North Carolina has taken that step. And there are about 9 other states that are in the process of either submitting an 1115 waiver or doing some type of pilot process to look at Medicaid reimbursement for medical respite care. And I just want to plug quickly, we have a resource coming out at the end of December. Annually now, we're doing a state of the states document that shares an update on where we are as it relates to state level commitment to medical respite reimbursement. So that resource will be coming out in December, but what we're learning is that it's growing. And so it's a really important conversation to figure out as there's more and more interest in partnership between managed care or Medicaid partners and medical respite and recuperative care organizations. How can we build those partnerships in a way that people understand the role, each other's role, the work that each side does? What are some of the challenges and pain points related to this? And that's really the purpose of the discussion this afternoon. So Pam, I would love, just coming from the managed care perspective, and I know you've negotiated contracts on behalf of recuperative care programs, you used to work in a managed care plan, so I think you live and breathe that language pretty well. But I'm wondering, how have you worked to to build some cross-system partnerships on the managed care side?
Well, I have to say, having the Los Angeles Learning Network, the Recuperative Care Learning Network, and I have to apologize to all of you from other states. In California, we have a tendency to call it recuperative care, and everywhere else in the country, it's medical respite. So those words are used interchangeably. But negotiating a contract between a recuperative care provider and a managed care plan is just the first step. And it seems like it's a lengthy process in California because these recuperative care facilities are unlicensed. It's interim housing with case management and all the things that Julia and Krista, mentioned. Because it's unlicensed, there is no so we're having to create everything as we go. And because there is no the whole certification process and the credentialing process that the plans go through with medical providers is not appropriate for community-based organizations. So the state delegated the credentialing process to the plans, which in that process has required, a pretty complicated process. So the plans, the recuperative care providers reach out to the plans, say we're interested in a contract, and then they get invited to submit a provider certification application, this is because of the credentialing process. They've required a lot of information, and Julia Gaines is nodding her head because she's gone through this process as a recuperative care provider. But they want policies and procedures. They want to know your workflows, and so initially, I'd have to say, when I first negotiated contracts with health plans in 2018 for NHF, I actually used NIMARC standards of care, which were at that time, they were interim, to convince the plans that the recuperative care providers had some standard. And that's one of the most important things that I think, regardless of the state you're in, that you follow NIMARC standards of care process, that when the certification process is available, that you go through that, because the plans are used to having, credentialed providers. Hospitals are credentialed, doctors are credentialed, and DME providers, ancillary providers. And so we're breaking new ground and pioneering, to get the health plans to contract with non-clinical providers. The other thing is, once the contracts are in place, you know, I don't know literally how you do this, Julia, without a learning network, without bringing all the parties together, because we thought initially it was going to be just the managed care organizations and recuperative care providers that were going to be the key partners in the learning network. And then we found out how critically important it is to have the hospitals at the table. And so we partnered with the Hospital Association of Southern California, which has, you know, access to all the hospitals. And their vice president of patient access services, Ana Reza, you know, became part of the learning network. And she gave us access to about 225 hospital discharge planners and social workers. So we're obtaining information, the whole referral and authorization process. You know, a lot of you have been getting referrals from hospitals and paid by hospitals. They don't go through an authorization process. Health plans have to authorize the service. And so that added a whole level of complexity. In LA County, we had 6 different plans with 6 different processes. I also want to quickly mention that the state, because these are in recuperative care, isn't in lieu of service. It's not a benefit. So it's at the discretion of the health plans to decide if they're going to authorize. It's not something just because somebody is unhoused that they're entitled to. And so we've been working very closely with the state as well on giving feedback as to what is and is not working. One of our huge successes of the learning network up front was we kept getting complaints from the hospital discharge planners and the recuperative care providers that it was taking too long to get an authorization. For example, the hospital would reach out to the plan and say, we have somebody ready to discharge. We'd like to put them into recuperative care. And they had 5 business days to turn around an authorization, which equaled 7 days because of the week, which meant an unhoused person is sitting in a hospital bed that could be used for somebody else. And so we reached out to the state and said, this is not working for anybody. And they said they would investigate. And within 2 weeks, they said effective immediately, all California Medical managed care plans must turn around the authorization from the inpatient to to the recuperative care. And then we had another interesting, thing happen in that we realized the state shared with us that the statute included referrals from emergency departments. And so, hence we're working through that right now, because you can't have somebody sitting in an ED bed for 72 hours waiting for the authorization. So some of the plans, HealthNet, for example, has put in place a presumptive authorization, meaning the hospital can reach out to the recuperative care provider and get the person there. They presume that the person is eligible for the first 30 days if additional days are needed. Another issue is figuring out how to get paid. So there's a whole list of things that we really have been rolling up our sleeves, unwrapping these issues, bringing together the various players to see how best do we work this out. And then we can submit through NIMARC's extensive resources, we're able to submit to the state and educate them, because just because your state might be in the process of submitting an 1115 waiver to CMS to be able to offer this, it's the eligibility criteria needs to be defined. And so, I think as a result of our hard work and the hard work of many other people throughout the state is, finally realizing they need to standardize these processes. And so we're looking forward to the standardization that is going to go into effect on January 1 of 2024. So that's kind of I don't know if I've fully answered that, but there are the reporting, getting the reports. The plans need to know what your capacity is, on a monthly basis, so that everything that the plans have to report to the state, and then the state has to report to CMS, they now need you. So these are all functions that recuperative care medical respite providers have not been doing. And so we're sort of, massaging some of these and trying to figure out the best way. And thankfully, the health plans in California, while some of them were initially resistant, they've come around, they've been changing, they've been working very collaboratively with us. And so NIMARC helping facilitate these partnerships, and the Learning Network has really helped bring people together to better understand, helping the recuperative care providers understand what the plans have to do. And some of those things that they think they have to do, they can just shift a little bit with subtle changes, which makes a huge difference, because the bottom line is the plans would like to get these people off the street into housing. They'd like to have their healthcare needs addressed, their behavioral health needs, their supportive services needs, and the hospitals want to get them out of the hospital into the right place. The recuperative care providers wanting to get discharged to some type of interim housing. And so I'm just grateful to, been a part of this and to be able to help facilitate, because the goal is successful partnerships that are win everywhere around. It's got to be a win for the hospitals, a win for the plan, and the win for the recuperative care providers, or it's not sustainable.
Yeah. There's so much to dig into with what you said there. And I think it's great because we have a bunch of folks who are joining us on this webinar who are based in California, but we have a lot of people who are outside of California. And this is helpful information just around a lot of states are looking to California to see what California has done and what they want to replicate. And so these hard lessons learned, I think, are useful for other states to consider. Of these are the types of in the weeds conversations and challenges, and really figuring out the operations pieces that are going to need to come once you start moving in this direction. And we'll talk maybe a little bit more towards the end of the call about recommendations for folks and resources that we can connect you to. But Julia, I would love to hear from you about COT's experience around building partnerships that have had good impact on your program.
Sure. Yeah. I mean, this is just such a big topic. But, our recuperative care program, traditionally accepted referrals from hospitals. We are, and we still do, we're funded by, one-time, annual payments from the hospitals. And in turn, we, accept their patients for a post-acute stay, generally up to 90 days, but depending on the patient's need. But with our managed care organization, and we're in Sonoma County in the San Francisco Bay Area, so we're not as big as LA. So we have one managed care organization for our county, and they've just been amazing partners. And their name is Partnership Health Plan, and we were just kind of learning together. We were all in the same boat, both the managed care plan as well as our organization. So it was been described as building the plane while you're flying it, right? And that's how it felt for a very long time. Our organization was all in, so it wasn't just recuperative care. We do other community support, but we assessed our ability to and our capacity to be able to provide the services as our managed care organization wanted them performed. And and again, we just decided we were all in, and the Department of Health Care Services in California, we did receive a grant through them to build the necessary infrastructure to support this program. We hired a consultant to launch the program off the ground. We have a full-time CalAIM administrator who handles the ongoing management of the partnership with the managed care organization, as well as the reporting, which does change, regularly, which is absolutely fine. There's a lot of flexibility there between the MCO and our organization. But we made some changes to our organization in order to be a CalAIM provider. We modified our internal database so we can capture the client data that isn't captured in HMIS, the Homeless Management Information System. And we developed an internal CalAIM team that still meets weekly to this day, just to stay up to date on what the changes that happen with the Medicaid reimbursement. So yeah, just I guess a little bit about how we maintain this relationship. I mean, as I mentioned, the reporting does change. It's based on what state of California is looking for. And we again do have a CalAIM administrator to manage that. But basically it's monthly reporting. We share through secured portals. We had to get HIPAA compliant. So protected health information, was protected by extra security measures through our internal and external communications. And we hired, we were able to hire more staff. Thanks to the CalAIM, benefits, and we could better meet care management needs with more staff and just to deliver better quality of services. And the way we continue to maintain a relationship with the managed care organization is they hold weekly roundtables that all of the organizations that are participating in CalAIM attend. And it's just a very open forum. They give us updates on what's going on, with CalAIM, any reporting changes or anything like that. And we're able to ask questions, and they've been, if I could give, the managed care organizations, any tips for working with recuperative care programs, it would be just to, stay in great, of course, excellent communication, but, be willing just to work with each other and give each other some grace, because again, this is a brand new playing field for so many, and for both parties, really. It's actually our managed care organization, once we use a care plan to submit with our treatment authorization request, the TARs, and they kind of graded how well our case managers were doing that, and they hosted a meeting to go over each question and how we could better answer those questions in order to get the service approved. So really, I mean, they've done nothing but tell us that they want us to be successful in implementing CalAIM, into our services. So, sorry, I feel like I was a little all over the place, but it's so big and there's so much to talk about. Yeah, that's been our experience, and we've it has changed our organization, but it hasn't. It has changed our services, but for the better, absolutely.
Great. So Pam, I have a quick question for you just around, at this point in time, most states still don't have medical respite as a reimbursable service. And still in many states, managed care plans are partnering with medical respite programs, even though they're not billing specifically for medical respite care. And the intention of this playbook is not just for people in California and Washington where medical respite is a reimbursable service. It's for people in every state. And this is even our friends in non-expansion state. I say our friends because that's where I live. That's where Krista lives. So much of the medical respite team are in non-expansion states. But really thinking through how medical respite programs can use this resource to approach managed care plans and talk to them about their work, and why, even though medical respite might not currently be a reimbursable service, why it's still worth partnering with medical respite care. Pam, can you just talk a little bit about what those partnerships look like for states where it's not a reimbursable service? And we have some resources around this on our website as well that will include in a follow-up email to folks.
Sure. Actually, when I negotiated the contract, I leased up all the beds for NHF for a new facility in 2018. The Medi-Cal managed care plans could not use their Medi-Cal. They couldn't put it in their medical loss ratio. So they had to use administrative dollars, they had to use profits. And so this is not the current case with Cal-AIM, but this would be my recommendation that in my capacity as VP of LTSS and long-term care, I was struggling with what to do with people who were unhoused that were discharging from the hospital. So I went out, we were in the middle of a duals demonstration. I went out and contracted with PATH, which is in LA, which is a shelter organization, and also was in the process of negotiating a contract. Actually, at NHF, we were in communications, so that when I left, they knew that I understood the other side. And what I said is to NHF, before we start meeting with the plans, I need you to look at your processes so that you would be willing to tweak how you do things if that's what the plan needs you to do. And one of the things, the reason I recommended the leased beds is because then it's a payment up front at the beginning of the month from the plan to you, and they own those beds. We were really finding that the plans wanted to know that they had a certain number of beds that were for their unhoused members, and that nobody else could use that. So I encourage you to look at that option. It's different than having to go through the authorization and having to use the claim process. The other thing is, being able to quickly respond. We wanted in the leased beds. The other thing is the hospitals, contact the plans and say this person is ready to discharge. They need to be able to quickly move those people into a bed. Mm-hmm. They needed to have, TB clearance. They needed, and then through the pandemic, they had to have a COVID clearance. There's certain requirements. And so everything that you can do to work with the hospital discharge planners and to show the plans, you already have those partnerships, and that your job is to expeditiously get them what they need, and then also be able to share information back. And so one of the things that we created were interdisciplinary care team meetings that were part of the duals demonstration, but those interdisciplinary care team meetings allow the recuperative care provider to participate with the PCP, with other providers that may also be serving this individual, and they get everybody on the phone, and sometimes they get everybody on Zoom. And it's powerful when you can share what you found out, what's needed, and you become part of an extension of the health plan's care management. The other thing I want to really quickly say is every Medi-Cal managed care plan, every Medicaid managed care plan in the country can pay for services that are needed as part of the care coordination process. So what we're doing in California is calling out that we can cover certain community supports. They've also made enhanced care management, which is it's the holy grail of care management programs, because the lead care managers are responsible to navigate the person throughout the care continuum. But health plans still they can, if they don't have a contract with you, they can do a letter of agreement with you to accept it, each person at a time. There's a lot of different ways to skin this kitty. And so I think that, it's really important for you to say, not dig in your heels and say, this is the way we do things and you have to accept it. This is a compromise of coming together. There are certain things the plans cannot compromise on. These are CMS requirements, these are state requirements. But I think that the more you work with NIMARC and the more you work with this group, you can come to us with your issues, with your problems. We can help you problem solve. We can, help you come and negotiate from a position of strength. because you know how to take care of this population. And I've got a newsflash for you. The health plans don't know how to take care of people who are unhoused. And the majority of the primary care physicians in this country don't know what to do with these folks. This is a huge challenge. And so one of the things we're in the process of implementing is we're having the street medicine providers work with the recuperative care providers. We're looking at, being able to get ADL assistance from the outside, a provider to be able to come into recuperative care to provide ADL assistance. So these are projects that NIMARC is leading, that Kaiser is funding, that we're really excited about, because we'll be the guinea pigs in California, but we want to be able to have you benefit from our lessons learned, so you don't have to go through what we've gone through in the last 2 years. And the plans can also offer advice that, this is what we've experienced and this is what we would like you to do. So I encourage you to come open to ideas, knowing that, it needs to work for you. The rates need to be high enough. You need to get enough referrals to make it worth your while. And what we benefit, what Julia Gaines is referring to, is the state of California had $4.228 billion in ARPA funds that they've put into 3 pots of money that they're able to help the recuperative care providers build their capacity, hire staff, buy the technology, the case management software system, whatever it takes for you to be able to serve more people. And so hopefully that's, a message that, states have gotten loud and clear is, there's a heavy lift.
Mhm.
And so, it does take time. And because it's taken us 2 years to get to where we can look up and say, oh, wow, we've had a lot of successes. But
Yeah.
be willing to be open.
Yeah, I want to comment just on, I think this is why partnerships with managed care plans are so important, is because the people who are doing medical respite work in their communities, recuperative care work, often have a long history in healthcare for the homeless or homeless services. So that really is your expertise and is not necessarily the expertise of managed care plans. And yet they have members who are experiencing homelessness. So this partnership is really important. It's mutually beneficial. And we just want to make sure people are getting the level of care that they need. I think I appreciate you talking about the leased bed component here. That is highlighted in the playbook, just what different payment approaches can look like. And I think that's helpful both from the medical respite perspective of understanding what a payment structure could look like, and from the managed care plan of understanding how to make this work when it is not currently a reimbursable service, maybe in your state. And somebody had put in in the question and answer space that they have leased beds in their community with their hospital, and their hospital is really seeing their program now as like a hospital step down program, and they don't really have a lot of control over who's referred to that program. And this is something to negotiate when you are leasing beds, to say, yes, you're paying for this bed space, but this is our admission criteria. This is who we're safely able to address. And I just want to acknowledge that that tension is very complicated, especially since we know across the board, more and more of our folks are fragile and showing up sicker and needing higher levels of care. So we hear a lot about the pressure on medical respite programs to take folks who really are needing a higher level of care. We are running out of time, so I'm going to ask John, if you will launch the poll. And in our last 2 minutes, so if people will take a couple of minutes to complete the poll before jumping off, that would be really helpful for us. And I just want to touch on some recommendations for moving forward. So I think one of the things, obviously, use the playbook, share the playbook with your partners. I think understanding that you might need to build some infrastructure in order to have a partnership with managed care, and for managed care plans to understand that medical respite programs might have to build some infrastructure. Julia talked about creating a new data system or an EHR. That takes time, that takes money, that takes staff. A recommendation around building a network or a community, if you're in a community that has more than one medical respite program, get together with them and ask them about what their relationships look like. And can we bring everybody to the table to talk about the network of medical respite in our community and what these partnerships look like and how we can streamline them to make sure nobody's getting dropped. In our last minute here, Pam, you have 30 seconds to make one recommendation, and then Julia, one other recommendation you would make to folks.
Know what it costs you to do business. Know your expenses. NIMARC has a budget tool that you can use on its website. I think that you need to be able to go to the table knowing what your nut is, how much you need on a daily basis to be able to provide that care.
Perfect. Julia.
Yeah, I mean, just really just to emphasize what we've been discussing is, be flexible, give each other space to work out the kinks, in the process, and look to the other as the expert in that area, right? The housing or the recuperative care provider is, has the experience of working with these unsheltered folks and providing this care, and the managed care organizations are experts in their area. So, just trust that and really just keep on collaborating with each other. Yeah.
Thank you. Thank you so much, Pam and Julia. Thank you to our Kaiser partners, Tiffany and Vanessa. Thank you for joining us. Thank you, Krista, for your awesomeness all the time. Thank you, John, for your support. And thank you to everybody for joining us today. The recording will be sent out to you. Please visit the NIMARC website, a ton of resources there. And please reach out to us if you have any questions or if there's any way we can support your work. Thanks, everybody. Take good care. We'll talk to you soon.